Next speaker is Dr. Kiran Kumar, Cataract and zonular weakness.
Thank you very much. Thank you very much, AIOS, for giving me this opportunity. Zonules are thread-like structures that connect lens to the ciliary body. They are present 360 degrees all around. If there is no zonules, lens will fall into the vitreous. The main causes of zonular weakness in our clinical practice is one is pseudo-exfoliation, another one is trauma. Then in trauma, we get not only zonular weakness, there are multiple other associated anterior segment and posterior segment features. We have to take care of those things. Lens-induced glaucoma, both phacolytic and phacomorphic glaucoma, hypermature cataract, and hard brown cataract where the lens thickness is very much high. In these cases, there will be a zonular weakness. The lens and iris coloboma, spirophakia. Spirophakia is generally a bilateral condition in which zonules are very much seen after dilatation of the pupil. Other main causes of zonular weakness, what we see in clinical practice is glaucoma, Marfan syndrome, Will-Marchesani syndrome, homocystinemia, iridocyclitis, retinitis pigmentosa, and after a pars plana vitrectomy, intraocular surgeries like trabeculectomy, high myopes, and very old age. In all these cases, there is a chance of zonular weakness. And we have to look for preoperatively whether there is zonular weakness is there or not in every case. The main preoperative features are one is phacodonesis, another one is if the lens is displaced a little bit posteriorly, iridodonesis will also be seen, and subluxation and dislocation of lens, which will be seen mostly undilated people. We miss these things, and if you only after dilatation only we can see the subluxation or dislocation of the lens. Other associated features are low endothelial corneal count and irregular AC. That means either it means a shallow or it is a deep or it is irregular. If the lens is a little bit posteriorly displaced because of weak zonules, in such cases AC will be deep. And if there is a phacomorphic glaucoma, in those cases the shallow AC will be there. If there is a trauma, at one part the lens will be tilted. At one part it is a deep and at one part shallow, that is irregular AC, and there are small people. Although in all these features, if we see all these features, we have to suspect a zonular weakness behind. Intraoperatively, when we try to do the capsulorhexis, the capsule will not tear. Instead of tearing, it will fold on itself. This is the main sign we have to note there is a zonular weakness and we have to take care of. And there will, in zonular weakness cases, there will be a difficulty in nucleus rotation because the zonules will stretch, will fumble. It will not, if the zonules are taut, nucleus will easily rotate. If the threads are loose, it will not rotate. Nucleus rotation will be difficult. And cortex aspiration is very difficult, although phaco itself is difficult. After phaco over uneventfully, even cortex aspiration is much more difficult because aspiration port will try to catch the anterior rim of the capsule. Then if you drag it, then there will be zonular dialysis. IOL implantation is very difficult, especially if the pupil size, rhexis size is small, because weak zonules, during IOL implantation also, there is a chance of zonular loss. That means at each and every step of phaco surgery, starting from capsulorhexis to the implantation of IOL, there is a chance of zonular damage in these cases of weak zonules, in all the cases which we have already seen before. While doing surgery, what we have to keep in mind is, one is whether the zonular weakness is focal, that is limited to a few clock hours, that is a 2 clock hours, 3 clock hours, or much more than that, or it is global, all over the zonules, all zonules, like pseudo-exfoliation, all zonules are weak. That we have to keep in mind. If there is a trauma case, if the focal loss or focal weakness of zonules, how many clock hours and what is the location, superior, inferior, temporal, and nasal? Because inferior zonules, if they are very weak, the chances of difficult surgery and post-operative decentration of IOL is much higher when compared to superior, because this is because of gravity. So we had always keeping our incision, phaco incision, and also putting IOL, we had to keep these things in mind. How to tackle during surgery? Rhexis forceps, normally many people we do with the 26 gauge bent needle cystitome, but in these weak zonules, Rexis forceps, either Haldipurkar forceps, Inumera forceps, retinal microceps forceps, or whatever, that gives much control over Rexis. And capsule hooks are very useful in these cases in the way when the journals are very big. CTR and CTS are also useful. And when to insert a CTR, when to insert a CTS, it depends upon the surgery, because where the surgery goes difficult. At that step, we only will put a CTR. These are the instruments. If you are tackling with a weak joint, these are the instruments we have to kept ready with the regular cataract surgery, because these things we don't kept ready, because in a normal case we don't keep this one. So these things has to be kept with Rexis forceps, CTR, CTS, capsule rings. All these things should be kept ready, and this is a in weak joint there is a hole in the CTR that could be tied to the scleral fixation. That can be scleral fixation. This is we created a scleral pocket here, and these CTRs can be sutured to the sclera, so it won't. The journals will be much better stabilized. All weak journals are always associated with some other factors like small pupils. So in such cases, we have to use small pupil expanders, like previous surgeons showed that iris hooks and rings, Malyogan ring or BHEX ring, whatever it may be, and good endothelial protection, because pseudo exfoliation like cases and trauma cases are always associated with low endothelial count. So good viscoelastics containing sodium hyaluronate and chondroitin sulfate is very good option in these cases. And there are different thoughts of how to do Rexis. The small Rexis are normal size 5 to 5.5 mm is
1 minute more.
Good. But some people thought that some school of thought is the large Rexis is good. Avoid excessive hydrodissection, and don't start the hydrodissection at the weak journal spot where the journal nucleus drop will happen. So always start the hydrodissection at where the journals are very strong. And during phaco also we should not pressurize much to the posterior, that is on the lens. So it's a direct chop instead of trenching. The direct chop technique is very good in these cases. And cortex aspiration, there is already we had told that the chance of jonular dialysis, the here aspiration port dragging the capsule, and then jonular dialysis is happening. So always keep ready these two things. One is anterior vitrectomy. We have to keep in mind there is always chance of vitreous loss in these cases because of jonular dialysis. We have to keep that in mind. And if there is a nucleus drop, post-planar vitrectomy should be kept ready. IOLs, there is a 3-piece hydrophobic foldable IOL, that is haptics in the sulcus, optic capturing in the back is a good option, and single-piece hydrophobic foldable IOLs are also good. Hydrophilic IOLs, yes, there is a capsular phimosis. SACS is particularly very good in this section, and iris claw IOL, SFIOL, ACIOL, if there is total jonulus, we have to keep it in mind. So jonulopathy is not uncommon. Capsule hooks, CTR, and pupil expanders has to be ready in the OT, and direct chop phaco is the technique of choice, and hydrophobic 3-piece or single-piece hydrophobic are good. SACS PMMA IOL is very good option, and vitrectomy should be backup. And in case of total jonular loss, if there is ICCE, iris claw, scleral fixation, ACIOL should be kept ready. Thank you very much.
Very nicely covered, Dr. Kiran Kumar. A small tip I would like to share. Whenever there is zonular dehiscence, in that area you do the cortical aspiration last. Because if once you pull it and it goes off, rest of the cortex remains. So try and finish off all that and then you access the last. Anyway, thanks a lot.